Welcome back to another episode of the Braun Performance and Rehab Podcast. Joining me again today is Luke Way and Andrew Sellars. The three of us are going to be diving into continued discussion on the respiratory system and breathing, this time in more relation to medical applications, in particular of the Isocapnic device. I'm a huge fan of Isocapnic, and I think that a lot of the different things that we discuss have very broad applications across the medical and healthcare field. Episodes like this are made possible by our sponsors, ISOFIT and Oro. For more on ISOFIT and Oro, you can check the description below. Enjoy. Luke, Andrew, welcome back to the podcast. I'm super excited to work with you guys again. Thank you so much for being here.
Thanks for having us.
For people who might not be familiar with the two of you or Isocapnic, or maybe they just missed that first episode we did, would you mind filling them in a little bit about who you are and all the great things that you all are doing?
Sure. Our background is in applied physiology. We worked a lot with sort of Olympic-bound athletes, primarily in the endurance world, but that is vastly spreading to the strength and conditioning world these days. That's our background is physiologic testing of high level athletes. We needed a better way of training their respiratory systems. Through this testing that we've done, it became very apparent that many of the athletes that we work with were limited. Well, not even just limited, but actually they couldn't progress in their sport because of their respiratory system, and so we were trying to find a better way to apply focused stress on their physiology so we could actually make them better. In our research, we couldn't find anything out on the market that was adequate for our use. So that was the necessity behind the invention. So we invented a product, a device, a system that allows us to leverage the full potential of the respiratory system, unbridled from gas exchange. And that's sort of the secret sauce of what we're dealing with is we allow you to breathe harder and deeper and for longer than you ever thought possible, unbridled from the notion of being tied to hyperventilation. If you were to take 5 or 10 deep breaths right now, you'll probably start to feel a little bit faint. If not, you might faint. So don't do that. If you want to breathe that hard, then you can use our device and train it properly.
And I feel like that has such broad applications in the health space in general. I know we've talked about it in relation to human performance in the past, but correct me if I'm wrong, but Andrew, I believe you're a anesthesiologist by trade. And I would imagine concept like gas exchange and breathing is really, really important for the work that you do with the patients that you see on the day-to-day.
Yeah, that's actually, that is my day job, is doing anesthesia in a relatively small town in Canada. And I spend my entire working life watching people breathe under various levels of physiologic stress. So yeah, I literally spend my life and my career watching people breathe and thinking about how to maximize their ventilation to make it functional and healthy and keep them alive and safe and comfortable. And interestingly enough, the original research on respiratory training and the effect and the potential effects was actually done on COPD patients, so chronic obstructive pulmonary disease, usually as a result of smoking, unfortunately, or exposure to toxic gases. And those people with really poor lung function were seen to have really poor exercise tolerance. And what the researchers suspected was that the decline in their performance of activities of daily living was as related to their respiratory system as it was to other systems. So what they found was that if you could train their respiratory system to be stronger and more functional, it would overcome some of the limitations that they had functionally in their walking ability. And the biggest study that was done now over almost 25 years ago, was a simple 6-minute walk test with people with severe COPD. And these patients were severe, so they were barely covering 200 meters over 6 minutes. So this is half a lap of the track in 6 minutes. So the intervention was specific respiratory training using a device that rebreathed CO2 so they could train for 20 minutes at a time. And their performance increased, almost doubled the distance that they could walk in 6 minutes. So literally 100% improvement in performance for these patients. Now this is that really select group of patients who have really bad lungs. But the same goes for kids with asthma, patients with cystic fibrosis who have a primary lung disease that limits their performance. And what happens is they become deconditioned because their performance is so poor, they can't go out and walk, and they can't go out and play soccer, and they can't do the things that healthy people should be doing to stay active. And they become deconditioned, and then the muscles atrophy, and all the bad things happen from not moving. By overcoming the limitation of the respiratory system, you can now actually train them to become better physical beings and more capable of doing the other things in their lives that allow them to stay mobile and stay active. And that really is the focus from a respiratory training perspective, is trying to get these patients back to as close to normal living conditions as they can and being as active as they can again. So it really isn't that different than training an athlete. It's just on the other end of the bell curve. So whether you're training a top end high performance athlete who's aiming for Olympic gold or world championships, that's one end of the bell curve. And the other end of the bell curve are the really sick patients who are, at risk of being admitted to the ICU or need to be ventilated or intubated in the hospital. That's the low end of the bell curve. We know that the respiratory training will help everybody in between those two extremes. But the medical side, for sure, there is a ton of interventions that we are starting to look at. We don't actually have medical licensing yet to be able to sell to the medical market specifically, but we do have the ability to promote and support the use of respiratory training for everybody, regardless of their situation, because there's no harm to it. And so that's the work we're doing right now, is actually we're funding a few studies to help actually show the benefits in a specific populations. And the big groups, of course, we just mentioned COPD, asthma, cystic fibrosis, and the other group is the perioperative group. So the people that are actually coming to see me in the operating room for an anesthetic, whether it's for a knee replacement or a hip replacement, and we know they're going to be laid up for a number of weeks and not being able to exercise, and the potential benefits of doing respiratory training as a modality to help them continue to move their lungs and move the respiratory system while they're recovering from their other injuries or from surgery.
Yeah, I was just going to add that we are actually working with respiratory therapists and different athletic therapists that deal a lot with this affected population. And they're actually starting to develop protocols with our device to help people through this process, help them survive and recover from being intubated, and getting through their disease.
Yeah, you bring up so many amazing points. I mean, just to kind of run it back, first off, Andrew, as you were talking about COPD, you mentioned about exposure to toxic gases. Well, I don't know if you've ever looked at the ingredients label on, I don't know, anything in today's day and age, but whether it's like the cologne that people are spraying, or, we work sometimes with the tactical athlete population, and, a lot of the gear that they have to wear on to literally protect themselves is actually toxic. So it's one of those things where pretty much everyone is exposed to some level of toxins every single day. So having an almost additional buffer layer, or, for lack of a better way to put it, metaphorical ozone layer for the respiratory system on top of that certainly seems like a beneficial thing. And, as you were talking, Andrew, I know you don't have the medical licensing yet, as you mentioned, but, there's certainly no harm or potential risk that I can think of from improving our ability to breathe. I mean, studies show the more you breathe, the better you're going to live, or longer you're going to live, I think. I haven't met people that don't do too well when they're not breathing. So I think that there's a lot of potential benefit to it. And on top of that,
that's a fascinating comment, because actually there was a study that just came out that showed that the maximal ventilation that is measured during VO2 max testing is the best predictor of all cause, of reduction of all cause mortality, which means if you breathe a lot, if you're able to breathe a lot at maximum intensity, you will live longer. It even has a correlation to a lower risk for cancer. It's shocking how much breathing is a predictor of the rest of your life and the length of your life. So absolutely, the more you breathe, the longer you'll live. That's a simple solution to the studies that have been coming out, and that really is our philosophy. We help people breathe better, we'll help people live longer.
And it's one of those things, who doesn't want to live a longer life or live a higher quality of life, and it's not too early to start, talking about these things or training these things really. And the other piece, as you were mentioning, different patient groups that you work with that way, whether it's COPD or asthma and so on that way, we live in today's day and age where a lot of athletics and fitness in general is very inclusive in nature. So, we have adaptive programs now that didn't exist 15, 20 years ago. And a lot of athletes or a lot of individuals, regardless of diagnosis and regardless of limitation, can actually find ways to engage in, fitness or physical performance type of things. So it's one of those things where we almost have to look at, I think the buzzword term right now is exercise is medicine, but maybe breathing is medicine as well. And instead of being, so quick to look at various pharmaceutical agents and other things to address respiratory related things, we should consider how could we supplement or augment those with respiratory training.
Yeah,
Absolutely.
yeah. I was just going to add in that yes, breathing is the key, but exercise is also the key. Like what we're doing is not magical. Like we are not like unlocking some cheat code for longevity and fitness. It's literally we're just unhandcuffing people and trainers from the risks that have been otherwise associated with trying to train the respiratory system. Because we're controlling CO2 now and you're no longer bound by hyperventilation, exercise is the medicine, and exercise specifically around the respiratory system is what we're specializing in with our device.
Yeah, another good example of that is we absolutely want our cardiac patients, so people who have suffered an MI or have been identified with coronary artery disease, we want them to go out and walk every day. But some of them are so limited by their cardiovascular system that they actually can't walk very far, or they also have bad knees or bad joints and they're overweight and they have high cholesterol. We can help them be better walkers by addressing one of their limitations, which is the respiratory system. So they can do a good breathing warm-up, they can train the respiratory system, and then they can go for a short walk, then they can come back and rest, and they can do it again later in the day. So it's one piece of the bigger puzzle of all of the exercise that is going to benefit them in the long run. And you're absolutely right. Exercise is medicine. I'm one of those physicians that is absolutely dismayed at how our medical system has medicalized everything and treated it with a drug or an intervention that really should be treated first with exercise. And hypertension, high cholesterol, diabetes type 2, all of those things should be treated with exercise. They shouldn't be treated with medications. It's just way lower side effects and way better benefits by focusing on exercise first.
Yeah, no, definitely. And it's interesting you brought up the perioperative group not that long ago as well. Is, plain and simple, a lot of athletes and individuals that are coming to see me from a PT side of things have probably undergone surgery at some point, whether it's ACL or, some kind of joint arthroplasty or whatever it is that way. And the thing I've noticed about a lot of these people is they don't like being told when they can do certain things or what they can do and can't do. And, we almost pull the locus of control from them entirely and shift that into the hands of their medical provider. A lot of times I feel like we get better outcomes if we start to give people things that they can do as opposed to focusing on what they can't do. And it's one of those things where respiratory training could be done pre-op, but could also be done post-operatively. I mean, I don't see any harm in having an athlete sitting on a couch and doing respiratory training for 20 to 30 minutes after a knee surgery. Like, obviously, there's certain things we have to look at from the vascular system that could be related to that. Like, don't neglect palpating pulses, don't neglect checking for DVTs and that sort of thing. But, plain and simple, if you want to give your athletes or the people that you work with more things that they can actually do that will have benefit after a surgery like this, to me, respiratory training seems like such low-hanging fruit. It's like, how do we miss that?
Well, and the complexity of the physiology and the potential benefits for wound healing and infection prevention and all of those things have been shown to be positive with increased oxygenation. And if you breathe deeper and breathe faster, even with our device, you will actually increase oxygenation to the muscles. So you will actually recover faster by doing some sort of deep breathing. And this is the benefit of doing, a runner who has an ACL injury but can be on a bike. And some of the benefits that we get from the bike are actually probably from the increased blood flow and all the other things, regardless of actually just rehabbing the ACL and strengthening the leg. It's the increased blood flow and it's increased cardiovascular dynamics, increased breathing dynamics that they can get to on a bike. The benefit of ours is that while they're not on a bike or they don't have access to it or they're lying in a hospital bed, they can actually already start raising their heart rate, raising their oxygenation levels, raising their CO2 levels potentially a little bit, which actually also has cardiovascular and peripheral oxygenation benefits. These are all physiologic knowns that help with recovery process. So reduction in post-op infections, increased oxygenation and speeded wound healing. All those benefits for surgical patients are known from a physiologic perspective, and our device would help with that, absolutely.
Yeah, so I'll tell a quick story. We're working with an athlete that unfortunately was hit by a drunk driver a little while ago, and she needed to end up with back surgery. So she had lower lumbar issues and needed to go in for emergent surgery. And so she was doing respiratory training up until the surgery date to make sure that her respiratory system was strong. So we had protocols in place to help with that. And then her post-operative regime was just as Andrew's saying, helping to drive more hypercapnic, hyperoxygenated blood to that traumatized tissue. That hypercapnic state shifts that deoxygenation curve over, so it actually dumps more oxygen into the traumatized tissue, helping with that recovery process.
I see, that's so interesting too, because my mind, as you were talking about that, also went right to the, pain side of things, pain science and the self-reported pain side. And once again, Andrew, to reference your point earlier about things that are treated often with medication that maybe don't always need to be, it's so quick and easy to throw medication at pain. And I've noticed a lot of people, even athletes, who literally will take 6 ibuprofen before their games because that's what they've always done. When in reality, maybe there's other physiological factors in play that we need to address that could kind of go into addressing that pain from a more deeper, complex level, I guess I'll say.
Yeah, I think that's a great point. I can't speak enough to the over medicalization of everything that for every patient. And I think the first response from the medical system really should be, how do we holistically help these people not take medications and use medications as a backup for interventions that are healthy and don't have side effects. And breathing and exercise doesn't have negative side effects. So let's start with that. Let's start with meditation. Let's start with breathing. Let's start with moving actively and functionally, and then improve the rest of the healthcare system after that. Yeah, moving away from medication is going to be the best thing we can do for most patients.
And Luke mentioned a minute ago about the hyperoxygenated state. And, in my mind actually went to the brain from that. And I would imagine that, increasing oxygen levels, the brain seems to eat oxygen quite readily. It's a very metabolic tissue, for lack of a better way to put it. So I'd imagine that there could potentially be some kind of cognitive effect or cognitive benefit as a result of respiratory training as well. And I know that we talked, more about the respiratory side of diagnoses so far, like COPD, asthma, cystic fibrosis. But, hypothetically, I guess in my mind, I could potentially see a mechanism where it might improve someone with more of like a central nervous system, regulated limitation that way, or central nervous system type of diagnosis.
Yeah, it's a fascinating theory, and you're probably right. We obviously don't have any evidence about that. We haven't been around long enough to be able to study that. But those are the kind of areas of research that we need and would love to look at, because you're totally right. If someone we know that exercise itself has a benefit to the brain. Physiology, no one's figured out exactly why that is, but people who exercise think better and survive longer and have less risk for strokes and less risk for other forms of dementia. One of the best treatments for dementia is activity, physical activity. And And you're right, it is probably a complex mix of oxygen-rich blood getting to the brain and maintaining healthy neurons and cross reactions. But it hasn't been fully figured out what the crossover benefit is. But you're absolutely right. It is probably related to oxygen-rich blood and blood flow up to the head, and we can absolutely benefit that by breathing better.
Yeah. I mean, we just posted a video on our Instagram showcasing some work we did up at Mount Everest Base Camp. The idea of what we were trying to do was just get over acute mountain sickness symptoms. But the fact that it not only reoxygenated the system, but it also like made brain fog go away. It made headaches go away. It made the nausea go away. Like there is more research needed to explore exactly what's going on with this. But very exciting that these preliminary looks at these different ideas is it's making a difference, which is ultimately our goal. Our goal is to bring respiratory fitness and wellness to everyone, and that's been the goal from the beginning of the project, and we stay focused on that every day.
For those that want to put a couple of numbers to what Luke just said about overcoming oxygenation, Luke was saturating, his oxygen saturations were at 70% when he was at 5,100 meters, which is I think a little over 16,000 feet at Everest Base Camp. So he was having symptoms and his oxygen saturation was 70%, which for you and I sitting at anywhere close to sea level is usually up in the high 90s, 98%, 99%. Luke went from satting in the low 70s to 98% just by using the breathe way for 5 minutes. So the overcoming of oxygen saturation at altitude is the same thing we would expect to see at low altitude with people who are having problems with their breathing, is if you actually put them on a device, they will oxygenate better. They will have better brain health for sure.
Yeah, no, that's a super fascinating reference. And even to the point that you brought up there, Luke, on the headache and that sort of side of things as well. You know, I can't tell you how many times athletes or individuals will travel to those higher altitude states and, you know, not to beat a dead horse, but they'll go right back to the medication because they get a headache.
Yep.
And it's like, maybe there's something else at play here, and maybe there's other things we could do to treat those symptoms that inevitably pop up when we go to these higher altitude types of settings that way. And it's so interesting because, again, I think we've said it a few times that our understanding of respiration and our understanding of blood gases really is not where it should be, in my opinion. And I think that recognizing that some of these symptoms that people might come and see us for from a clinical standpoint are actually underlying signs of some type of respiratory dysfunction, and we could treat the respiratory dysfunction instead of just treating the surface level symptom.
Yeah, great insight.
I feel like there's a lot of potentials for this. And you mentioned protocols a few different times as we were talking. Anything that's come up as far as protocols go from the respiratory therapists and other individuals that you've worked with thus far, or where would you start on the actual implementation or application of respiration from a medical standpoint? And how does that differ based on some of these different conditions or diagnoses that we mentioned?
It comes back to similar to what we talked about from the sports side, is that the fundamental part is first learning how to breathe and learning how to breathe properly and efficiently. And so all of our basic programs have a learn to breathe aspect to it. So we teach proper dynamics and proper motions first, and then we start into training at a really basic level. So our app has programs that are specific to beginner levels, and I don't think it matters whether you're suffering from COPD or asthma. Any sort of beginner level respiratory program that's within our app is going to help, because it's going to focus on proper breathing dynamics and then slowly work you through the ability to increase duration and increase respiratory flexibility. So the ability to breathe deeper and longer, and then coordinating faster breathing and over longer periods of time. So it really doesn't matter whether it just, again, on the bell curve, if you're starting at the lower end of the bell curve with really poor respiratory health, the ability to breathe deeper is going to help you. The ability to control your breathing through full range of motion for longer periods of time is going to be a benefit. And then the ability to be able to change the speed and the dynamics of how fast you can do that is also going to improve over time with focus. And your progress may be slower, especially if you have true lung disease, because your ability to move air isn't as good. That's the obstructive part of COPD is there's actually reduction in the ability to move air quickly out, which is why they have an expiratory wheeze when they're blowing out. They actually have restriction to blowing out. And asthma in a similar way, although it's a different mechanism, different pathophysiology of why that is. There may be a slower development of improvement in performance with those specific populations, but the process is still the same. Start easy, start simple with learning to breathe properly, learning to breathe efficiently, and then slowly build up speed over time and duration that you're able to do it.
A reasonably common excuse that people give me when talking about using our device is that, oh, their respiratory system is too far gone, or something like that might be too hard for them. But it's important distinction that our device is not a constriction device, and you don't have to fill up the bag. You don't need to have the lung capacity to absolutely like maximize like the full volume of the bag. Like, my mom is 5'0" and she does great with this size of bag. I have another athlete that has 9.5 liter lungs, and he uses the same bag. So those principles of like, this is just too hard for you, they actually don't apply here. There's no resistance to push through. It doesn't work in that way. It's literally just recapturing the gases that you blow into it, allowing you to find range of motion, allowing you to work that system through duration to get stronger.
And I know the device kind of has a mouthpiece that you would breathe in and out the mouth through that way. I'm sure someone is going to make a comment at some point about, but what about nasal breathing, or what about breathing through the nose? So is it okay? Is it safe? Is it okay to kind of breathe through the mouth for this across all populations? Or, is there a nasal adapter that, could allow you to possibly breathe through your nose for this as well?
Yeah. So first of all, the basic device, you're right. It comes with like a snorkel-y type mouthpiece where it's primarily mouth breathing, and that's because the idea and the philosophy is that we are trying to challenge the respiratory muscles themselves, the diaphragm, the intercostals, accessory muscles thereafter. And so the orifice that you're breathing into when we're just thinking about those muscles is less important. For more meditative style breathing, where the ventilation rates are closer to 60 liters per minute or less, then nasal breathing becomes a lot more beneficial. We get that nitric oxide working. We get that more controlled sinusoidal wave pattern of breathing, where you're smoothly breathing in, smoothly breathing out, because of the smaller orifice to breathe through. And because of that, we actually have a mask version of our device that's going to be available probably when I get back from this trip to Death Valley.
Do you feel like that mask type device would have increased carryover to other types of settings, like Andrew's work in the anesthesia space, since typically it's got more of a mask type of setup that way, from what I've experienced myself in the operating room?
Yeah, absolutely. The adapter we have that turns our mouth breathing into a mask breathing nasal adaptation is exactly the same kind of quality mask that you would use in an anesthetic room. So it allows a perfect seal, so that you can either nasal and mouth breathe at the same time, or just focus on nasal breathing. And yeah, as Luke mentioned, there are some benefits to doing nasal breathing, and with recent literature like Oxygen Advantage and Breathe, those books, highly influenced current understandings of breathing techniques. And so, yeah, we've responded to those by creating the opportunity for those that want to do nasal breathing and also train the respiratory systems and the muscles at the same time. They'll have the option of doing mouth or nasal breathing.
Has there been any interesting case studies or case reports or any type of medical, I don't know what the right term is, but anything that you've found through Isocapnic thus far that's really caught you off guard or surprised you at how effective it was or how well it worked or that sort of thing?
Now we're less surprised because we've been doing it for so long. My biggest surprise is that the physicians that I work with or talk to haven't heard about respiratory muscle training, or don't understand it. There is a clinical group down in Vancouver that are looking at potential perioperative applications for it, which is great. I have a couple of colleagues who are back down in Vancouver and starting to do some research. I'm hoping to connect them and with our group to be able to support the research that they're doing. Yeah, there's literally thousands of studies now on respiratory training, and like I said, the original ones were on COPD and asthma, which showed a clear benefit to when you take those patients that have a respiratory limitation. It went to sports because it was easier to do. It's easier to get athletes to sign up to improve their performance than it is to get patients to sign up to improve their health, which is a baffling way. Maybe it's a commentary on why our populations are so unhealthy right now, but it is challenging sometimes to get patients to recognize that they are actually the master of their own domain, and they have the ability to change their future. And that really is part of what our education is about, and part of what we're trying to do is to make it so easy that people can actually see that they can get better, and they can stop being frustrated with the fact that they can't walk around the block with their dogs, or they can't play with their grandkids anymore. This is an option to help them improve their activities of daily living and actually live a longer, healthier, fitter life, so that they can enjoy their later years with their kids and their grandkids.
Well, and it pairs up with your current routine really well. It's not like you have to displace yourself to go and go to a clinic or a gym to do this. You can literally be answering your emails or watching Jeopardy while training your respiratory system and getting a stronger ability to breathe.
Well, not to mention, you've referenced the app a few times. I would imagine a clinician, regardless of title, PT, MD, whatever, that way could potentially develop their protocol and then deliver it through the app and monitor through the app, so you actually have the ability to assess what your patients are doing when they're not right in front of you, because those office visits are never quite long enough for any of us. And it's something that we can certainly see compliance and so many other factors that a lot of clinicians are always thinking about and considering. So the more we kind of bridge that gap between what is happening when they're in front of us in the office versus what they're doing outside of our eyes, the better outcomes we're going to get across the board. And thus far, I've never met a clinician who doesn't want the best possible outcomes wherever they are. So any little thing we can do to better provide for the people that we serve at the end of the day, I think we should be doing.
Yeah. One of my best mentors, he was a physiotherapist, and he would set up a respiratory training session he would charge them a single physio session, and then set up his gym. So he had an open gym format that people could come and do their rehab, but they weren't allowed to step into the gym part until they'd actually completed their respiratory training. So while they were putting their socks on and getting ready and getting changed, he just had the respiratory training devices there, and they would have to complete 15 minutes of respiratory training, and then they would step onto the mat and start doing their other physio. And it was people were paying really good money to be able to come and have access to the gym. And he said, this is part of what you need to be doing to get better. So I'm just including it as part of your program. And they're like, okay, I get that for free. And he goes, yeah, it's the most important part. So he was actually, in hindsight, he was actually charging for the respiratory training, and the gym was free, is really what he was doing, because he actually felt that the respiratory training was the biggest component to their improvements. And so it just became part of their system, is just like walking on a treadmill for 5 minutes before they start. They would breathe for 15 minutes before they started walking on the treadmill.
I feel like we could probably talk about this stuff all day, and there's a lot of concepts we covered and a lot we didn't. I mean, I'm sure Luke could probably nerd out about alveoli physiology and that sort of thing till we're all blue in the face, pun intended, blue in the face, breathing. But is there any kind of closing thoughts, closing remarks, or anything that we missed that you guys really wanted to bring up today?
My big thing is that if anybody who's watching this has questions or is interested in reaching out, and whether it's from research questions or or clinical questions, feel free to reach out. We love answering questions, and we love talking to people about this. You're totally right. Luke and I could spend all day doing this. This is our passion. This is what we do. So if people have questions, feel free to either reach out through you, Dan, or they can contact us directly through isocapnic.com or on Instagram. And we'd be happy to continue conversations and continue the research and better understanding of how to help people breathe better.
Absolutely. And we get, messages all the time from different researchers looking to explore this world. And, we want to help out however we can, making sure that, the third pillar of our process is the hardware that just works, the app that tells you what to do, and then the knowledge base behind it so people can understand and get the most out of this idea. And so, partnering with smart folks that are exploring these ideas is a big piece of what we're trying to do.
Andrew, I know you mentioned your online platforms. That way, we'll link to all of that in the description below. That way, if you didn't quite catch it, you can just click there. Love what you guys are doing at Isocapnic, and I really appreciate your time on the podcast today. Thank you so much for everything.
Thank you, Dan.